Hey everyone, welcome back. Today we're taking a deep dive into the world of causal inference, and this one is particularly relevant for all of you grad students out there wrestling with statistics.
Yeah, definitely a lot of complexity in this field.
It can be a bit of a jungle out there, and that's why we're talking about ablation studies today. They're like a secret decoder ring for these really complex causal inference models.
It's kind of surprising how often we see these super intricate models proposed, but without anyone really stopping to ask, wait a minute, are all these moving parts actually necessary?
It's like using a jackhammer to hang a picture.
That's a good one. And that's where ablation studies come in. They help us break down a model piece by piece and see which components are actually driving performance and which ones are just along for the ride.
And the paper we're looking at today is a perfect example of this. It's all about the Bayesian causal forest model, or BCF, and whether it actually needs to use the estimated propensity score to get the job done.
Right, and the BCS is already being used in real studies, so making sure it's as streamlined and interpretable as possible is pretty crucial. Before we get into the nitty-gritty of the paper, though, maybe we should take a step back and explain why this whole propensity score thing is such a big deal.
Yeah, let's break it down. For those who might not be super familiar with propensity scores, can you give us a quick refresher?
Sure. So imagine you're trying to figure out if a new drug actually works. Ideally, you'd randomly assign some people to get the drug and others to get a placebo. That way, any difference in outcomes is probably due to the drug itself and not something else.
Right, because that random assignment helps make sure the two groups are pretty similar in terms of other things that might influence the outcome.
Exactly. But in the real world, we don't always have the luxury of random assignment. Think about observational studies where we're looking at data that's already out there. We might be looking at who chose to take a certain medication or who signed up for a specific program.
So in those cases, we can't be sure that the groups are balanced, and that can throw off our estimates of the treatment effect.
And that's where propensity scores step in. They try to estimate the probability of each person getting the treatment based on their characteristics. And then we can use a score to adjust for those differences between the groups and get a more accurate estimate of the treatment's effect.
So it's like a statistical equalizer to make up for the lack of random assignment.
Precisely. But here's the catch. In models like BCF, using this estimated propensity score might actually create a new problem. Regularization-induced confounding, or RIC for short.
Oh, that sounds a little scary.
Yeah.
What exactly is RIC and why should we worry about it?
Okay, so it's a bit technical, but bear with me. When we have a data set with tons of variables, we often use something called regularization to prevent our model from overfitting, basically becoming too focused on the specific data we're using and not doing well with new data.
So regularization is like adding a little bit of blur to a photo. It loses a little detail, but helps the overall picture look more natural.
That's a great analogy. So regularization helps the model hone in on the most important variables and not get bogged down by noise. But sometimes this process can accidentally create a fake correlation between the treatment effect we're trying to estimate and the propensity score.
So it's like the regularization itself creates a new kind of confounding. It makes it look like the treatment and the propensity score are related even when they shouldn't be.
Exactly. And that's where the authors of the BCF model came in. They were concerned about this whole RIC issue, and they came up with a way to address it by directly incorporating the estimated propensity score into their calculations.
So they're basically saying, if this propensity score might be causing trouble, let's just include it in the model and control for it directly.
Exactly. But as you can imagine, adding another component to an already complex model comes with a cost. It makes the model more complex and it takes longer to run.
Right, because now it has to do even more calculations and juggle more variables. Yeah. And this brings us back to the big question of the paper. Is that added complexity actually worth it? Does including the estimated propensity score actually make the BCF model perform better? Or can it handle confounding on its own?
That's the million-dollar question. To figure this out, the researchers took the classic data science approach. They whipped up some synthetic data sets.
The beauty of simulation. It's like having your own personal laboratory for testing out all sorts of scenarios.
You got it. And they didn't just create any old synthetic data sets. They drew inspiration from recent research by Balinari and Berth, who designed a set of rules for making synthetic data that would be super tricky for causal inference models.
So they intentionally made the data sets extra hard. That's kind of like training for a race by running uphill both ways.
Well, kind of. Think of it like this. If you only ever run on flat surfaces, you're not going to be ready for the hills in a real race.
Okay, so they wanted to really push the BCF model to its limits, and see if it could still perform well even with these tough data sets?
And exactly. And to make things even more interesting, they really zoomed in on a specific scenario where RIC was likely to be a big problem.
Okay, now I'm really intrigued. Tell me more about these data sets and how they set the stage for this epic battle between the BCF model and the dreaded RIC.
All right, so let's talk about these data sets. They were designed to really test the limits of causal inference models. Remember how we were talking about RIC? It becomes a bigger problem when the thing we're trying to measure, the outcome, is super influenced by all those other variables, the covariates, rather than the treatment itself.
Oh, so they basically created data sets where the outcome was way more driven by those other factors than the treatment, like setting up the model for a fall.
Exactly. They used something called alpha to control this balance, and for the main analysis, they cranked alpha up to 4, which means the outcome was like 13 times more influenced by the covariates than the treatment. It's a recipe for confounding, for sure.
Wow, that's like trying to hear someone whisper in a rock concert. No wonder they wanted to see if the BCF could handle that.
And there's more. They also played around with the level of targeted selection. That's the idea that the treatment might be given based on how someone is expected to do without the treatment. It's kind of like a doctor being more likely to prescribe a certain medication to patients they think will really benefit.
So it's not just random who gets the treatment. There's some logic behind it. And that can bias the results too.
Right. They tested the BCF with different levels of this targeted selection, from super strong to moderate to weak, just to see how it would perform under different conditions.
So they've got these tricky data sets where the outcome is heavily influenced by covariates, and there's varying degrees of targeted selection, all to test whether the estimated propensity score is actually needed. But before we get to the results, how did they test the BCF?
They actually tried a few different approaches. They compared the BCF in 3 configurations, one with the estimated propensity score, one with the true propensity score, and one with no propensity score at all.
Hold on, the true propensity score. But wouldn't that be impossible to know in a real study?
You're right. In real life, we can only estimate the propensity score, but since they were working with simulated data, they actually knew the true propensity score. Think of it like peeking at the answer key.
Ah, I see. So they could see how well the BCF did when it had to estimate the propensity score versus when it had the perfect answer. That's smart.
Exactly. It gave them a baseline to see how much the estimation process was affecting the model. And then, of course, they also tested the model with no propensity score at all to see if it could handle the confounding by itself.
Okay, so they have their challenging data sets and their 3 BCF configurations. And then they ran the simulations. But before we jump into the results, let's talk about how they evaluated the model's performance. They mentioned a bunch of different metrics in the paper.
Yeah, just saying the model did well isn't very scientific. We need concrete ways to measure accuracy and reliability. They used a whole set of metrics. Some looked at the accuracy of the treatment effect estimates, and others focused on measuring uncertainty.
Let's start with the accuracy metrics. They talked about RMSE, MAE, and MAPE.
Yeah.
Sometimes all these acronyms make my head spin.
I know what you mean. It's easy to get lost in the jargon. RMSE stands for root mean squared error. It measures the average difference between what the model predicts and the actual true values. So basically, lower RMSE means the model is doing a better job of hitting the target.
So it tells us how far off, on average, the model's predictions are from reality.
Yeah.
Got it. What about MAE?
MAE stands for mean absolute error. It's similar to RMSE, but it focuses on the size of the errors without being too sensitive to really big outliers. Like saying, okay, on average, how far off are we, whether it's an overestimate or an underestimate?
Okay, and then there's MAPE, mean absolute percentage error, right?
Exactly. MAP shows us the average error as a percentage. This is helpful when you're working with outcomes that are measured on different scales.
So those 3, RMSE, MAE, and MAPE, give us a good idea of how accurate the model is.
Yeah.
But you also mentioned measuring uncertainty. What's that all about, and why is it important?
It's important to remember that even the best models are working with limited data. They can't predict the future perfectly. There's always some uncertainty around their estimates, and it's important to be able to measure that.
So it's not just about getting the right answer, but also about knowing how confident we can be in that answer.
Precisely. And that's where coverage and length come in. Coverage tells us how often the true value falls within the range the model gives us. For example, 95% coverage means that in 95 out of 100 cases, we expect the true value to be within the range the model predicts.
It's a measure of how reliable the model is.
Exactly. And length refers to how wide those ranges are. Ideally, we want them to be narrow to give us a precise estimate, but not so narrow that they miss the true value too often.
It's a balancing act between being overly confident and too vague. But why did they look these metrics for both average and conditional average treatment effects? What's the difference and why does it matter?
Good question. The average treatment effect, or AEE, gives us the overall effect of the treatment on the entire population. It's the big picture. But sometimes we want to know how the treatment effect might differ depending on certain characteristics of individuals.
Right, because not everyone reacts to treatments the same way. Things like age, lifestyle, or even genetics can influence how someone responds to a drug or an intervention.
And that's where the conditional average treatment effect, or CATATE, comes in. It lets us estimate the treatment effect for specific groups within the population. For example, we might want to know how a new blood pressure medication affects men differently than women, or older patients differently than younger patients.
Okay, so they ran their simulations, collected data on the model's performance across all these different metrics for both AE and CAT8.
Yeah.
And the moment of truth, they looked at the results. What did they find?
Well, remember that big question we had? Does including the estimated propensity score actually make the BCF model perform better? And the answer might surprise you. It turns out it doesn't.
Wow, no kidding.
Mm-hmm.
So all that work to account for RIC, and it might not have been necessary.
It seems that way. In none of the scenarios they tested, even the ones specifically designed to trip it up, did, including the estimated propensity score, make a real difference.
So the BCF model, even without that extra help, was able to handle the confounding in those complex data sets. It could find the signal in all that noise.
Exactly. And here's the kicker. Taking out the estimated propensity score actually made the model run about 21% faster.
That's a pretty big improvement. Talk about efficiency.
So it's like the model was saying, thanks, but I've got this.
I like that. But let's dig into those performance metrics a bit more. Were there any that really stood out? Well, across all the metrics, the differences between the model with the estimated propensity score and the one without were super small, and none of them were statistically significant. This was true for both the average treatment effect and the conditional average treatment effect.
So it wasn't just a fluke for one specific type of treatment effect, it was consistent across the board.
Right. It really seems like the BCF model is strong enough to handle these tricky situations where RIC might be a problem.
And this finding really challenges the idea that we absolutely need to include the estimated propensity score to deal with RIC in models like BCF.
So what does this all mean for those of us who are using or developing causal inference models? What if I'm using BCF to analyze data from a clinical trial, for example?
Yeah.
How should this study change my approach?
If you're currently including the estimated propensity score in your BCF model, this study suggests that you might be able to simplify things and maybe even save some computing time by leaving it out.
But what about the risk of RAC? Shouldn't we still be worried about that?
It's a good question, and it's always smart to be cautious. But what this study seems to show is that RIC might not be as big of an issue for models like BCF as we initially thought. Of course, every situation is different, so you always have to think carefully about your specific data and research question.
So there's no easy answer. It's all about using our judgment and weighing the potential benefits and risks.
Exactly. And that's where the art of data science really comes in. It's not just about applying methods blindly. It's about understanding the subtleties of each tool and picking the best one for the job.
This study is a great example of how we can use ablation studies to really take these complex models apart and figure out what's really important.
Absolutely. It reminds us that sometimes the most powerful insights come from asking simple questions and challenging what we think we know.
So as we wrap up our deep dive into ablation studies and the Bayesian causal forest model, what are the key takeaways for our listeners?
Don't be afraid to question the status quo. Just because a method is popular or seems right in theory doesn't mean it's always the best way to go.
And never underestimate the value of a well-designed ablation study. It can uncover hidden gems about your models and potentially lead to more efficient, interpretable, and even more accurate results.
Couldn't agree more. And who knows, it might even spark new research questions and push our understanding even further.
This study has definitely done that. It's given us more questions than answers, but that's what makes science so exciting. It's a continuous journey of discovery, and each study is a step toward a deeper understanding.
Well said. It's exciting to think about what future research will uncover in this area.
And on that note, we'll leave you with that final thought. Be sure to check out the show notes for links to the paper and all the resources we talked about.
And keep those ablation studies coming.
Until next time, keep exploring, keep questioning, and keep learning.